Welcome to Veteran Cancer Talk by the Veteran Cancer Network. I'm your host, Ashton, and today I'm joined by Matthew Johnston, a men's pelvic health physical therapist who works with men recovering from cancer and other conditions that impact their quality of life. Welcome to the show, Matt.
Thanks for having me. I'm excited to be here and looking forward to sharing some information about pelvic health.
Now, wonderful. So, for people that are listening that have never heard of pelvic health floor for men, tell me what exactly is that and what do you do?
Yeah, I'm happy to. The pelvic floor is all the muscles at the bottom of the pelvis. So it's essentially everywhere that you are sitting on. Both male and female people have pelvic floors, but a lot of the conversation around the pelvic floor is especially related to like pregnancy and the time after pregnancy, postpartum care. Men have pelvic floors, obviously, and they can have problems in that area. And most of the time that deals with like anything related to bowel, bladder, or sexual function problems. Sometimes there's pain in that area, or sometimes there's side effects related to cancer care, for example. So chemotherapy, radiation, surgery, just to kind of name the top, usually like the top culprits.
Mm-hmm.
And a lot of the symptoms can be from like going too much, not going enough, so too frequent urination, constipation, for example, pain with, emptying their bowels or emptying their bladder, sexual dysfunction or pain with those activities. And then again, when we're talking about like post-operative care, that opens a kind of a whole other dimension of symptoms.
Now, I want to go back to the part where you were talking about cancer. So, what kind of cancers are you normally seeing in your practice?
hmm So the biggest one that I typically work with is patients with prostate cancer. That is probably the most common one that people will see physical therapy or pelvic floor physical therapy for. But it's not uncommon for certain therapists to kind of see specialty practice with like bladder cancer, colorectal cancer. Those are probably the big ones that affect the pelvis. Um, Sometimes general like oncology pelvic or oncology physical therapists might see like patients after testicular cancer, any of the abdominal cancers. But when we're talking about pelvic floor specifically, usually that's the prostate cancer, the bladder cancer, colorectal cancer most often.
So, what is it that usually actually lead men to come to you to seek care? I know you went over some of the common symptoms, but what are the ones that usually actually get them to say, okay, I need to go see somebody?
Yeah. So let's take prostate cancer for an example. Most of those patients end up getting what's called a prostatectomy or a prostate cancer surgery, where they go in and remove the prostate. And one of the biggest side effects to that is urinary incontinence. So this is leakage of the urine during a cough, a sneeze, laugh, lifting, walking around. So the urine is leaking when they don't want it to be. And usually there's a recovery time period where that is more likely to happen. Some patients get better on their own. Other patients need a little help, and they'll come to see us for strength training, some bladder retraining, so trying to teach the bladder to store things more normally, and a variety of other like treatment options to help get them recovered, back to their exercise, back to the things that they like to do. If they're active duty, they're getting back into physical fitness. So it really can be a variety of goals that the person needs, but most of the time they're coming in for urinary incontinence or leakage.
Now, are you seeing that there is usually like a time period of them waiting to be able to seek help? Or is there, I mean, I guess, yeah, what's that timeline, usually like? And why do you think, they wait so long?
This is a great question because it varies. I've seen patient, and a lot of this comes with the relationships that I have with their, surgeon or their, urologist. So that's a big caveat here. Like, if your surgeon or urologist has a pelvic floor therapist on call, like usually the wait time is pretty low, or they're being seen even pre-operative. So that makes a big difference. A lot of these patients don't know that pelvic floor physical therapy exists. So it can be really variable from when I end up seeing them. I've seen patients like 1 to 10 years after their surgery. I've seen patients pre-operative, so I see them before surgery and then take them into care after surgery, and we kind of help them manage symptoms afterwards. So it can be really variable, and I think a lot of it is just due to not being aware. not understanding that there are things that they can do about it. They can play a really active role in their recovery, and that there's things that they can do to mitigate, the leakage, and recover faster. A lot of the research just talks about people recovering faster or regaining their continence more quickly, and also returning to sport, activity, exercising, hobbies more comfortably and safer.
Now, I want to actually learn a little bit more about exactly what they're doing,
Mm.
and basically with you what that treatment is actually like. I've been to physical therapy. I know what it's like going and doing the exercise with the balls and everything else. But what is that like for pelvic health floor?
Sure, sure. Again, if we're going to stick with our prostate cancer group, a lot of that comes with like interview and intake. We're having a conversation about what they're experiencing, maybe some of their cancer medical history, but also what their goals are, what they're looking to return back to, why this is impacting them, how we can help with getting them back to important activities, right? So there's a lot of conversation in the beginning. There's a lot of education on like what is a pelvic floor, what do these muscles do, and what has happened during surgery that maybe leads them to experience these symptoms, right? So there's a lot of education in the early parts, and then we get to the examination process, and that probably looks somewhat similar to other physical therapy experiences. I want to see them move. I want to see them squat. I want to see them lift something, right? But when we're talking about pelvic floor, and this is the scary part, I think, for some patients, is that like what's going to happen next, right? Pelvic floors are a kind of intimate part of our bodies. So like what could actually happen in this, exam where I'm really not sure what's going to happen? Most of the time, if we have access to an ultrasound machine, we can take a video or a picture essentially of their bladder, and we can see the pelvic floor right then and there, and we can start with understanding how these muscles work. How well do they contract? How well can the patient control those muscles? What's the endurance look like? What's the speed look like? So we can kind of get an idea of like how those muscles are functioning and what the coordination of those muscles is like. And then we can start developing a treatment plan for them to get better control over them, more awareness, start applying that to some more like core, hip, and leg strengthening exercises. So probably the most unfamiliar part is like what's actually going on in the pelvic floor. And ultrasound is probably the best way to look at those muscles because it's non-invasive. We can do it standing. They don't have to undress, which is great. So it kind of really removes the scary factor to a lot of these patients. Not everyone has access to that. So if they don't, well, then it's maybe the more kind of standard or older, old-fashioned way of examining the pelvic floor muscles, which is typically the patient's undressed from the waist down, and we're examining them like laying on a table. And we're looking at those muscles and seeing how well they can contract, and we're testing them that way. There's some disadvantages of that because the person's usually horizontal, which is usually where the leakage happens the least often. So the benefits of ultrasound, we get them standing, we get them more in functional positions, we can see how they are upright. So there's really a lot of exciting benefits to that process. So
Now, I'm just sitting there thinking, like when I was going through physical therapy, obviously very different from what you're doing. But the goal, obviously, I wanted to be able to get some of that muscle tone back. So, and I've known this for, like when my husband was, going through cancer treatment and everything, it was all about trying to get that muscle back. And, you have that, there's always a stigma when it comes to, these type of conversations as well. But I'm curious how it's received while they're in clinic. Do you guys, are you guys able to, like talk about, hey, let's get the muscles down there really, really tight. And then I'm just sitting there thinking a bunch of guys in the gym sitting there working out as hard as they can. I mean, what is that like actually in the clinic? Are you guys able to kind of insert some, normalcy, some of that, that humor in it to get guys to be a little bit more receptive?
absolutely. I mean, my goal is really to get them out of the room, off the table, and into the gym and like doing things that are familiar to them, but also, I don't say quote unquote normal. I want them to get into as normal of activity as possible, as quickly as possible, and as dry as possible, right? So it's once they really understand that kind of basic foundational how do these muscles work and like build some momentum into that, we're very quickly getting them off the table. There's a lot of research that talks about hip strengthening, core strengthening, lifting, like returning to those physical activity, you know, things is really, really beneficial for recovery, for continence control, but also like I'm sure you maybe know this is like this 150 minutes of exercise for patients who are going through cancer, but also, recovering from cancer is huge. And we want to get them, promoting that, this 150 minutes of exercise per week and really trying to get them as active as possible. And sometimes the leakage is the thing that is stopping that, right? They don't want to go to the gym. They don't want to leave the house. They don't want to participate with their friends and family because they're afraid of the smell or the depends showing through their underwear or through their pants. They're afraid of, having to change in the bathroom. Maybe there's not a stall. Like, I don't know, people just start, putting up these barriers into why they shouldn't participate in things. And our goal as physical therapists, and especially as pelvic floor therapists, is to normalize these things, get people out and, back to normal life, back to their normal activities, and again, as dry as possible.
So how quickly can somebody start seeing results after, starting I guess the treatment protocols?
So these are muscles, and all muscles take a period of time to strengthen, just like if you're in the gym, right? You're not going to always see success right off the bat. So if we're looking at just the purely muscle side of things, we are looking up to 8, 10, 12 weeks for someone to really respond to that, like pure strengthening. Now, there's other things that we also do that are outside of strengthening that can make sometimes quicker changes, helping people understand to stay hydrated, to avoid things that maybe are irritating to their bladder, to work on their bowel health, to work on maybe just some education around like the right type of protective garment, so that they feel comfortable. So like there are things that we do kind of in the early phase that are outside of the strengthening. That's a through line for most of their treatment. But there's a lot of education and there's some other strategies that we can do to help maybe reduce some of the earlier leakage, because a lot of times there's some bad habits that happen that people are afraid to hydrate because they don't want to leak. They start pulling away from drinking water or their regular fluids, and then that actually can make the problem worse. So there's a lot of upfront education, and then there's the strengthening, that through line that we want most patients to be fairly dry by 12 weeks after surgery.
So how long are, as a patient normally going through, PT with you?
Yeah, and it kind of depends on their goals. I try to kind of respect everyone's demands on life and finances and all that stuff. So, most patients I'll see for that first 12 months, or first 3 months. But we know that there's some check-ins that happen at 6 months and 12 months. So I really want to kind of form a relationship with these people. So the active treatment phase is really that first kind of 12 weeks, first 3 months. And then we're looking at how well are you maintaining your fitness beyond that, right? Are you able to kind of stay active? Is there any regression in the leakage? Is it getting worse? So I'm really trying to kind of take a long-term approach to someone's health or their pelvic health, their cancer journey. But they're mainly with me for the first 3 months.
Okay. Now, do you see do you see people, once they finish up with PT, I'm guilty of it, where I stop, kind of doing my exercise on a regular basis, and then they have more of a relapse into their kind of old ways and then have to come back through? Or is it just that check-in and that reminder, and it's like, hey, make sure you're doing your exercises? What does that look like?
It sometimes can be a tune-up, right? Sometimes that someone comes back and say, hey, I got into cycling, or I got into weightlifting, or I got into pickleball, and the leakage is back, right? So maybe sometimes they have a change in activity, and that maybe spurs on some things. Maybe they had a change in their health status. They had to go back for radiation. They had a gallbladder removed. Something else happened. Maybe they have back pain or something like that, and that affects their leakage. So sometimes it's a tune-up, and we're seeing them for a course of care, 4, 6, 8 weeks. Other times it's a, hey, shoot me an email, later on, and we're just kind of checking in on their progress. And
So for those that, I'm curious because, obviously my husband and I are getting ready to cycle across, up to DC here in a couple of weeks. But for those that are, exercising on a regular basis, and they suddenly change and everything, is that a completely different, protocol on there, or are you really kind of tightening up the whole pelvic health floor, during those initial ones, or is it just targeted areas?
Yeah, so if we're getting someone right out of surgery or right kind of post-op, there's a little bit more standardization to that approach. A lot of it is geared towards their goals. So if they're into pickleball, we're doing a lot of quick movements and shuffling, and a lot of that towards the end, right? We're versus someone who wants to be primarily in the gym. We're doing a lot of lifting and kind of tailoring the program to them specifically. Um, Sometimes if something crops up later down the road, we might have to address the back pain first before we kind of recheck in. So it's about strengthening, but it's also about understanding what else is going on with this person's movement, right? Are they really stiff in their hips or stiff in their back? And we have to address those things. Sometimes that's like a precursor to really getting back into some of the strengthening. So it can be very varied. It's very like individual specific. There's some main principles that I think are best practice, and then I think there's also some things that are research driven, especially the strengthening that really should be done, and normalizing their bowel and bladder health. But otherwise, a lot of this is very individualized.
So is it ever too late post an injury or post chemotherapy or radiation or whatever for them to be able to come and see you? Because I know you said usually about 1 year to 5 years. But I mean, let's just say 10 years from now, if somebody's having issues, can they come and see you, or is that damage irreversible?
If we're talking about surgery, I do think that there's some benefits, and I've seen patients 10 years after their surgery who were just leaking a little bit. And sometimes we'll catch these people if they come in for back pain or hip pain or something else, and I see prostate cancer checked. I'm always asking them, how did you do? What's going on? Are you having any problems? So I think part of a lot of this and a lot of my professional kind of like education is about asking good questions, right? Taking the orthopedic therapist or the non-cancer or pelvic floor therapist to ask questions about, hey, you checked the box for cancer. What does that actually mean? What side effects are you dealing with? And how can we help you, right? Or I have a friend, or like, I know this colleague or this other therapist. Have you ever heard of pelvic floor therapy? Because the answer is 99% of the time no. So part of this, I think, is just trying to ask questions and learn about someone's experience. But I think on the surgical side, it's never too late. On the chemotherapy or radiation side, I think there's some things that it depends on people's problems, right? Like if there's still endurance issues or fatigue or stiffness, etc. There's always room for like building some resilience in their system, helping them to move better. So there's definitely benefits to seeing patients at any time. And I think a lot of it goes back to their goals, right? Is this limiting you from doing something? If you had chemotherapy 10 years ago and all is well and you're moving great and you're feeling good and you're doing what you want to do, well, the question of physical therapy is really kind of not needed, right? It's really more of like, I had this problem, I never really got back on my feet, I feel a little winded, that doesn't really want, that really affects me when I play with my grandkids or, I'm on the sports court or in the gym. Well, that's the great place for physical therapy. We can really help those folks kind of improve their endurance, their stamina, their strength, speed, power, all the big things that they need to get back and participate in those things.
Now, if there's, a man right now listening to this, what would you tell them if, they may, be thinking to themselves, I'm kind of experiencing this. What would be your advice to them?
Yeah, this is a great question because I think a lot of patients are dealing with these issues and they're by themselves. One of the questions I always ask everyone when they come in my door is like, have you talked to someone about this other than me? Sometimes I'm the only person, right? Like I haven't even talked to the doctor about this, or the doctor knows I'm leaking, but they don't really know how much it's impacting me. I haven't told my partner about this, right? I haven't told my children. So like, I think the big thing that I really would push is talk to someone about it, right? There's lots of groups. There's prostate cancer specific groups. There's obviously veteran associated groups. There are, usually the health system that you get your treatment with has a support group, and a lot of people are going through the same thing, and it's a great place to share if you're comfortable. If you're not comfortable with that, there are social workers that do great work. Your oncologist, your other medical team, your primary care doctor usually also has resources. So talking to someone, I think, is a great first step. Obviously, listening to information like this is also another good way to get information about not just pelvic floor therapy, not just oncology, physical therapy, but like how can you survive well with cancer beyond your treatment, right? So asking good questions, listening, And then finding resources, right? Finding help if you need it, right? Find your local physical therapist. Even the physical therapist you saw for your back pain can do something, but they also might know someone. They're typically in contact with their local pelvic floor physical therapist, and then you can kind of go from there. There's also lots of resources with the American Physical Therapy Association. There's some other organizations that have directories for pelvic health physical therapists that treat oncology or pelvic floor issues. So there's definitely lots of resources to find someone in your local area that might help and treat this issue.
Now, I do want to talk just briefly on other medical professionals. So I know from just my husband's experience, because I was there at almost all of his appointments, but I don't believe that he was ever offered up this type of, therapy services. I don't think he was ever really asked those questions. And here in a few minutes, if you guys are both up to it, I would love for him to be able to ask some questions as well, regarding this, maybe from a potential patient perspective. We'll see if he's comfortable with that. But when you're talking with other doctors, that don't refer over to, physical therapy on a regular basis, what kind of, I guess, words of wisdom would you sit there and tell them? Because again, it's not offered, in all medical practices, for this type of therapy.
Yeah, I love this question. When I am talking to a urologist or a medical oncologist or anyone who's dealing with these patients that are experiencing these problems, there's a couple barriers, right? Time is a barrier. There's a financial barrier. I think there's a lot of times where these providers they're I don't say burdening, but they're already putting a lot of information in these patients' court, and it's just like they don't want to add one more thing, right? So I think that's a huge barrier, and a lot of times the providers I've talked to is like, we just even think they want it to go, right? Like that's the last thing on our minds, that's the last thing on their mind, and I think that's a big barrier. I think the second barrier is either there's not enough providers in terms of physical therapists or pelvic floor therapists, or they just don't know who they are, right? They're working in a private clinic, they're working in a different health system. Maybe there's not someone who treats male patients in the health system that they work in. Maybe there's not a pelvic floor therapist in the health system they work in, especially in like the rural areas. That can be a big barrier. Usually, like your big metropolitan areas, DC, Philadelphia, LA, New York, right? There's multiple pelvic health therapists. You'll find a couple that treat men. That is growing and growing and growing over the last 5 years, and there'll be more. There will be more people treating male patients, so that's great. So I think a lot of times it's like providers don't want to burden patients with one more thing to do, or they just don't know someone. They just don't know. They don't have that resource in their back pocket or their pelvic floor therapist on speed dial to say, "Go see Matt. He'll take care of this issue." Would they work like the folks that I work closely with? It's all about forming relationships. I want them to understand what I'm doing. I want to understand what they're doing, and this needs to be kind of a two-way collaborative relationship. That helps them. That helps me. I learn. They learn. But the patient really benefits from that. And if your provider is resistant to physical therapy or helping to facilitate that, your primary care physician is always a great option, or like, advocate, have the patient be an advocate for saying, hey, I'd love to see, this physical therapist, this pelvic floor physical therapist, would you mind talking to them? Can you send them some information? Are there any restrictions? Like, should I not be lifting? Should I not be doing these things because of a medical, question or medical procedure or, surgical restriction, something like that?
Mm-hmm. Now, I do want to, just mention briefly, though, a lot of men, though, they're not going to, especially the military veteran community, we were always kind of told, suck it up a little bit, you're fine. If a doctor's not bringing it up, though, they're going to sit there and a lot of the times just dismiss, those as, I don't want to sit there and talk about it. It's embarrassing for them to talk about, but then it comes across as that the physician may be embarrassed to bring it up as well. So how do you respond to that?
Yeah, I love this. This is great because you're right. If my physician's not bringing it up, is this taboo or weird for me to bring it up? And but I'm dealing with this symptom, right? Something hurts, or there's leakage, or something's happening, right? Um, and I think sometimes this also happens in the sexual health department where patients are dealing with changes in their sexual health, erectile function, and no one's brought it up. And how do I start that conversation? Um, the way I typically talk to patients is like, hey, patients with prostate cancer experience these variety of symptoms. Does that sound like you? So I usually kind of start like that, and kind of normalize it, and then kind of ask the question saying, are you dealing with any of these things? I love surveys. I teach my orthopedic colleagues, or my non-pelvic floor colleagues to use questionnaires a lot, so the patient can just check things that are going on with them. And then as a provider, I can say, hey, looks like you checked a couple of these things. Can we talk about it? So it kind of opens the door. Well, what do you do if your physician or your provider on the other end is kind of reluctant or hasn't brought it up? I think part of it is just opening the door and say, hey, I have some things that I'm dealing with that are a little bit more private. Like, are you okay if we talk about it? Start there. Again, this is a great place for support groups where you might hear people talk about these things, or they bring in guest speakers a lot of the times to kind of normalize some of these topics. Again, the social workers tend to be like the oncology social workers are like the unsung heroes of these departments because they know a lot of these symptoms. They're familiar with a lot of these symptoms. They can help bridge the gap to the provider and help you either come up with the right words, or find some resources that might help you start that conversation. But again, a lot of this is very normal, but no one's talking about it, so it doesn't feel that way.
I find it interesting, because you're absolutely right. I mean, I think on the women's side, because we talk about everything, women tend to, overshare a lot of the times, according to my husband. I am guilty of that. But on the men's side, it's definitely not a common, a common thing to be able to talk about. It's often embarrassing. But like I know after my pregnancy, that was one of the things that was offered to me is try to be able to normalize, those conversations. Women's health very different than men's health, and trying to break that stigma. So I do love the fact that you're bringing in, different ways to be able to get in front of the men in your life. What would you tell the caregivers? Because I know caregivers are huge advocates, for their spouse and making sure that they're being heard. But what would you tell to the caregiver, to help her or him be able to get them comfortable to seek care?
Yeah, I've had a lot of patients bring their partners with them, and that's always a really interesting dynamic because you kind of hear that other side of the journey, right? Like, some of these problems affect them. Some they're also watching this person go through these experiences, so you can kind of see their experience. So part of it is like just listen, right? A lot of this is just like these people need someone to tell other than me and other than sometimes their medical provider. So part of this is just like, hey, I've noticed this thing. Do you want to talk about it? Or I've noticed that you're going to the bathroom a lot more than before. Do you want to? I've noticed that you don't have to talk about it if you don't want to, but I'm here if you do, right? So sometimes you got to plant a seed and then kind of watch it grow for a little bit before you really kind of push the envelope. Um, so I think listening is a really big tool in that, like the support person's, you know, toolbox. And I think if they're open to sharing and it doesn't sound like it's something that is typical or normal, all right, how can we help support you at the physician's office or, at your medical provider's office and maybe start some treatment process, right? Like, um, that I think can be a lot of times where when someone's not comfortable expressing something to a provider by themselves, like they have someone there, maybe they can like grease the wheels a little bit, and that sometimes I think can be really helpful because someone's giving you a little nudge in the elbow saying, "Hey, you told me about this, but you never mentioned to doctor. Can you tell them a little bit more about that?" And I think men, including myself, are kind of notorious for that. They just want to brush things under the rug, and these are not kind of normalized things to talk about. So let's just move on. And if I'm cancer free or if I'm healthy, I'm just thankful for that, right? A lot of people just say, I had cancer, I was diagnosed, I had treated, I'm in no evidence of disease state or remission, and I'm just thankful, right? So who cares if I'm leaking, or like I don't want to like, nag someone about some other symptoms that they're more quality of life things, right? So sometimes people feel kind of uncomfortable with that, especially if they had a particularly like, tumultuous cancer experience. So that I think can sometimes be another place where people are a little bit weary about talking about stuff because could this be a sign of something else? Or, they start kind of getting nervous about things.
Before I end anything, Casey, do you have any questions?
Hey, Matt. Thanks for being on today. But I do have some questions, as in, what would be a couple exercises you would recommend to strengthen your pelvic floor?
It's a good question. And I think a lot of times this is the question I think where patients go into a provider's office or they like go through the internet searches or they see these things on like forums or discussion groups, etc. And people start talking about like Kegel exercises or pelvic floor strengthening exercises. And they're kind of just like left out into the distance that says just strengthen or just squeeze. Like that's kind of the common like word that providers will sometimes use. And I think that's a misleading conversation. If we take someone who, the average Joe that kind of ends up here with leakage or something like that, and they're just like, the doctor told me to squeeze like a lot, and they're doing reps and reps and reps. And sometimes that's the answer to the problem, and like that helps a lot of like, a large chunk of patients. But there are some patients where that can lead them down other pathways, whether it's pain or it's just not effective. So we really want to think about like a lift of the pelvic floor, and I think that's kind of an important piece of it. So it's part of this is like individualized, right? It's like almost like teaching someone how to squat or deadlift or overhead press. Like their technique is going to be kind of a little individualized to their body's needs. And I think the pelvic floor is pretty similar to that. Yes, there's kind of a standard way to do that exercise or that lift, but it's not the, like one size fits all, right? Like a lot of times patients with leakage will end up getting that experience, but that might not be the thing that moves the needle for them, right? And then on the other side of like men's cancer health, some of them might not even need that, and they might need, bowel management or some sort of other like intervention strategy. So core work, I think sometimes can be really helpful. Hip strengthening can be really helpful. So we're just taking like the average person and like where should they start? Like walking program is great. Hip strengthening, core strengthening, like the basic like fitness things, principles that people will start with kind of on average is like my usually recommendation. If you're not moving, start moving, right? If you're already moving, like can we do some strengthening that's going to kind of be beyond that? And then you can link up with your pelvic health physical therapist and like refine the pelvic floor piece of it. So I kind of hesitate to like go into the logistics of a pelvic floor contraction because it is kind of unique and like what makes, patient A's pelvic floor contract the way we want it to, and patient B, sometimes the wording of that can be a little bit different. And that's where it kind of becomes this kind of really individualized process sometimes, not all the time, but so that's kind of, I guess, my answer to that.
Oh, yeah, that's a good answer. I like it. It's not pinpointing one thing because it's not a one-size-fit-all matter. Mainly just get out there and move. Didn't you say 108 minutes per week you need to move?
150 minutes of exercise per week. Yeah, 150 minutes of exercise per week. And that's usually a mix of aerobic and strength training. And the American College of Sports Medicine puts out that information related to like exercising in cancer care. So it's readily available online.
Okay, excellent. Next question. I already had it queued up in my mind, right? If you have a friend that is a veteran and you know that they're stubborn, whatever, they're not willing to go to a doctor, what would you tell them to try to convince them to go seek help?
That's a great question. My advice would kind of to go, I think this is the bias of being a physical therapist, but how is this impacting you, right? If you're dealing with this problem that you don't want to go tell someone about or open the can of worms about what's going on with your body, what are you not doing? What can't you do? Like, is this impacting your ability to play sports or with your kids, your grandkids? Is it affecting your work? Is it affecting your sleep? Like, what is this coming, like, what's the why behind, like, you're obviously talking to me about it. So like, if we're friends and I'm hearing that you have urinary leakage or incontinence, but you don't want to tell anyone, all right, well, what's the root of the why? Like, why are you so afraid of it, right? Like, and then know that there's things that you can do about it, right? In a lot of cases, these are changeable things, right? There is a subset of patients that maybe don't, they need some more intervention or some sort of other like higher level treatment, but the vast majority of patients will improve with some kind of conservative strengthening and some basic movement stuff. So coming back to like why, like what's this impacting? How's this affecting you, and how can we kind of like use that to kind of coax you in the right direction and see someone?
Okay, yeah, I like it. I like it. That's some good, solid advice. Because veterans are stubborn anyway. They rarely get help, and when they do, it's already basically too late, or something bad happened, or they got diagnosed with something, and it's the last resort at that point. So, good advice all around. How can people find you if they have any kind of questions, possibly?
Yeah, so I am on LinkedIn. I post a lot of information about research. A lot of that's geared towards providers. I do stuff like this, so I've been on a couple other like podcasts. I can definitely leave my email if patients have questions, or if they're looking to like be linked up with a local provider. Sometimes I help make those connections. So I can leave my email in the show notes, definitely.
Well, thank you. Thank you so much.
All right, so I'm back. Now, I do have a follow-up question on exercising. So I know that for the majority of working adults, we are pretty sedentary, when it comes to a lot of our exercising. So they might only have like a Saturday afternoon or a Saturday morning to be able to work out. And I know actually a veteran that does this, where they say they do all their exercising in one lump sum. Is that helpful?
Good question. It can be helpful, right? I would say it's better than no exercise, right? But the interesting part is like, it doesn't need to be hours at a time that you're accumulating this exercise, right? 5, 10, up to 20 minutes in chunks can be enough to start accumulating over time. So that extra, 50 feet from the car parking lot to the store, or, instead of, like how can you add it into your day that you're already doing, right? Taking the elevator or taking the stairs instead of the elevator, walking a little bit further to the store, not driving to the next store, but walking to that store and then walking back. Like those are like such simple ways that you can start accumulating movement before you get, build habits, right? It's like about building habits, right? And like, can I take my work call and walk or stand, or like, how can I fit this into if I don't feel like I have the time and I'm like mass exercising on the weekends, how can I like, modify? Because this is a very typical thing for patients that I work with. They work at these corporate jobs or law offices or, government jobs. There's a lot of like office work, and that's the world we live in, right? Everyone's on the computer, and, it's hard to get up and move. We're not walking to other people's offices anymore, or working from home, and that's a whole different animal, right? So how can I incorporate that into the day without totally interrupting my workday? Do I take a lunch break? Gosh, so many people don't take lunch breaks. How can I start incorporating this into my, my life, right? And make small changes, right? You don't have to change everything all at once. You don't have to do the whole 150 minutes in one sitting. It can be small little bites that can accumulate over time.
Love that. I want to just tell the audience, Matt actually just talked about, some of the people at seeing doctors, lawyers, we got business professionals. This really can happen to anybody. Anybody can have this issue. So there's no shame in it. Being able to, go talk to Matt, or, reach out to us here at the Veteran Cancer Network, we can make that connection. But, at the end of the day, if you're having these issues, go get some help. Go ask Matt, go ask your provider at home. For this, basically just to get assessed. Matt, thank you so much for joining us on the show. We appreciate your expertise and the willingness to talk about a subject that a lot of people are a little afraid to even hear about, or they might just quickly scroll past on their phone because even at home by themselves, they might be a little bit embarrassed. So thank you for, being willing to share your expertise and guidance on this.
Yeah, you are most welcome, and you hit the nail on the head. Like some people just don't even want to listen to this by themselves, but like these are such normal problems. You're not alone. You're not going through this by yourself. These are common things. Not um, not normal, but they're common, right? Like so, tell someone, share this with a friend, because there's help out there, and there's therapists and other providers willing to help, and they're excited to help.
Absolutely. Now, Matt, I want to talk just in general terms whenever it comes to cancer and physical fitness, health, all sorts of things. So the first, it's a two-part question. So the first one, I know we talked a lot about prostate, and I think you mentioned colon cancer. What are some of the other cancers that are out there that can affect your pelvic health, or your pelvic floor health? And then second question, and you can lead right into it, is what type of exercises, or what kind of movement can be done whenever it comes just to cancer in general or major health concerns that make you sedentary in a chair?
Yeah. So talking about the pelvic floor, and in male patients particularly, there's been studies that talk about a lot of different cancer types that can either their treatment can affect the pelvic floor, the bowel, the bladder, or sexual function. Specifically, obviously the probably the second one that I deal with is colorectal cancer. People dealing with incontinence of their stool, so like leakage, constipation, bowel issues, some pain sometimes. So that's a common one, and it kind of makes sense, right? Like urination and bowel, like sometimes people those kind of click, but sometimes cancers that affect like someone's breathing, like pelvic health is a little bit more expansive than just the pelvic floor. So it has to do with everything that's kind of attached to your middle. So your abdomen, your breathing. So like people who get GI cancers or cancers in their abdomen that like get extensive surgical histories, or patients that have had treatments that maybe they end up in their chemotherapy chair and they're not moving a whole lot and their breathing starts to change. That might lead to some issues. So there's been a variety of like different cancer types that might affect pelvic floor, and a lot of them are because of the treatments that they experience. Most of the time that's surgical, but sometimes that can be chemotherapy related as well. And there's a lot of the research talks about like if you don't have a cancer that primarily affects your bowel or bladder, it's going to affect your sexual function typically, and we know that across like many patients with a variety of cancer types, sexual function issues can affect a large variety of them, like 40% of them, across the age span. So it can be something that, again, that's even a symptom that is less talked about, but your body has gone through a lot. There's been a lot of stress and challenge, and then sexual health might impact that, right? And some of that's because of you're not moving. Some of that's because of like the cardiovascular impacts of chemotherapy and other treatments. So there's a percentage of patients I think that are experiencing those symptoms that aren't talking about it with anyone. And I think again, like part of my job is to be the advocate, right? Part of my job is to be the question poker. Like I'm always trying to like poke the bear in terms of like have you talked to anyone about this, and not just like take it for what it like this is my lot, and I like there's nothing I can do about it, because there's so many like treatments are getting better and better and better, and there's so much more like technology that's helping patients recover from these things, or adapt their life, like resources that can really help them enjoy their health and their recovery, but maybe in a different way than they're expecting. So I guess that's one part of the question. The second part is about like exercising for patients in the oncology world. And this is, I think, a rapidly growing specialty in physical therapy, and it's becoming more and more popular. There's a specialty certification for therapists to go through for oncology rehab. So the education, the resources for therapists is growing rapidly, and that means that patients are getting access to those therapists. But honestly, your local neighborhood physical therapist should be able to start programs like this, like help you exercise. Like I don't think any therapist is going to like turn a patient away typically, or they're going to help you find resources for maybe someone who's more specialized. And then the specialist therapist is going to be more, more helpful for like those unique or rare cancers or like the symptom side effects that maybe are a little bit more challenging to treat. But just if someone's looking to get started in exercise and they're looking for a physical therapist, the average generalist could be really helpful. Again, a lot of this is like, if you're not moving, how can we get you moving? If you're already moving, how can we optimize that movement or load to that movement, put force through it or intensity, cardiovascularly, or just like by like strength training. So that's kind of the pathway that I kind of help most patients through. If there's someone who's just had like there's no pelvic floor issue going on, but there's a cancer-related fatigue or a stiffness or a problem related to like function. If you're not moving, let's start moving. And if you are, how can we optimize that or really like kind of push the intensity? And there's safe ways to do that. I think a lot of patients with metastases are scared or afraid. Again, that's where we work really closely with their medical team to make sure they're safe to do these things. We're monitoring their vitals, all that kind of stuff, to make sure they're a good candidate. But also that they have some own control over like how they move and like that they're not so afraid. We're building confidence, or we're building knowledge about how can I move safely given maybe the treatment experience I'm going through right now, or the survivorship that I'm experiencing.
No, I find that really interesting that they're moving forward, in the movement aspect of, because I know when my husband was going through, oncology, his oncology care and everything, he was just sitting in a chair for hours on end, just sitting there. His body started atrophying, he had the, I just remember because he was a very muscular man, and, then he ended up losing all that muscle mass very quickly. And it wasn't even, offered. They just kind of, basically expected him to just sit in that chair, for hours. So I do find that, quite promising, moving forward. But, what are some of the things that, that you would tell the doctors, for patients that are currently in the chair? Because again, a lot of oncology units are still not, kind of getting with, I guess, some more of the modern times on, health and nutrition and physical fitness.
Yeah. I think part of this, unfortunately, like sometimes these things need like a champion, right? There needs to be that physical therapist with that spark, or that movement professional, or that nutritionist, whoever that like squeaky wheel is sometimes. So sometimes it's that, right? Like in my my specialty area, it's, these providers they're busy and they're doing so much other work, and like they don't have the tools themselves to kind of help patients through like exercise or incontinence or whatever. It needs to be a collaborative relationship, and there needs to be a provider, a physical therapist, for example, that is looking to kind of take up that charge, and get excited and get patients excited and get providers excited about, hey, there are things we can do to this. I'm here to help you, right? I need them just as much as they need me. So some of this has to do with like finding a person who's willing to like start a program or learn more about it. And, again, the specialty is growing rapidly, not just pelvic floor, but oncology. So these programs are growing more and more and more health systems are really kind of picking up that charge for programs that are not just like years later, right? Like people are in the community, but also like in the medical system, like in the acute care floors, in the hospital floors, oncology floors, and then at the kind of the outpatient treatment where people are, there's movement that's happening, there's exercise, there's education, there's stuff like that while maybe treatments are happening. I'm gonna say it just depends on like, the person's like medical status and like, but where can we start? And if they're stable enough, like when can we start getting them moving? And again, there's fantastic therapists working in the hospital settings that are really kind of taking the charge for those patients as well.
Well, and I think it's also important to, remember that historically cancer has been more of a, older person's disease.
Yeah.
Now we're starting to see it in younger and younger populations who are physically active, so then you start seeing a decline in mental health as well. But when you are getting up and moving, at least, and I know when I get up and I start moving, I get those happy endorphins kind of going through the body too. So, getting up and moving is important, not just physically, but also mentally as well.
Sure. Again, like so much is happening to these people's bodies, and like control is taken away in a lot of these cases. But like, if I can start moving a little bit, if I can go and walk around the the hospital floor, if I can do something, like that's really powerful for patients. And you're right, like there is like an endorphin boost that happens, but there's also like things going on in the inside from like a muscular, cardiovascular, all these systems that are like, the bowels move better, right? Like there's all these things that are happening on the inside that really can be powerful to help, move the needle to like help people feel better. And it's about consistency and making like habit changes and like, how quickly can I get back to my normal self after this treatment process? It's like, put those little coins in the bank and that's going to help you on the other side.
Well, Matt, thank you so much for joining us at Veteran Cancer Talk. We appreciated your advice, your wisdom, and make sure for those that are listening, check us out on veterancancernetwork.org. Check us out on all of our socials. You'll see Matt's information. He's going to be tagged. So if you have any questions about pelvic floor health, make sure that you reach out to Matt. He is available to answer your common questions. Thank you again, Matt.
You're welcome. Thank you.